Good morning, everybody. Thank you so much for joining us. We are going to give everyone about 2 to 3 more minutes to join, and then we will get started. Thank you. Good morning, everybody. Thank you so much for joining us. My name is Tiffany Hewitt. I am a clinical program consultant here at HCSC. And today with us, we have Memo Sanchez to go over stopping antibiotic overuse. You can help reduce resistance. Memo Sanchez is an emergency medicine physician's assistant and epidemiologist. He previously worked as a as a physician assistant in a very large urban emergency medical department, as well as an urgent care center. He completed a CDC fellowship in applied epidemiology from 2018 to 2020. He is the first author on the CDC's core elements of outpatient antibiotic stewardship. His areas of consultation include creating CDC stewardship guidance, leveraging partnerships to promote appropriate antibiotic use, and supporting implementation of outpatient antibiotic stewardship, including among advanced practitioners with urgent care and telemedicine settings. Thank you, Memo, so much for joining us, and I will turn it over to you.
Excellent. Thank you. Without further ado, I think I'll just jump right into the presentation, but I'll start off by just saying thank you, everyone, for hopping on this webinar and for giving me the opportunity to talk to you. And that being said, I'd like to also extend a thank you to Blue Cross Blue Shield plans of the multiple different states represented on this call for the opportunity as well. For today's presentation, I'll review the epidemiology of outpatient antibiotic use, and also I'll identify high priority conditions, which the data show are great opportunities for improvement in many outpatient settings, including primary care and urgent care settings. But also I'll review some evidence-based interventions that can improve antibiotic use, and I'll address some common myths, which we have learned through some of the studies that we've done and some of the studies that we've seen published that I'm excited to share with you today. Antibiotic resistance is indeed a huge threat and a growing threat within our country. This is something I think that this audience will be particularly aware of, but suffice it to say, this is an issue that we'll see for the remainder of our clinical careers and in our public health careers as well. But according to the 2019 CDC threats report, there's approximately 2.8 million infections and 35,000 deaths associated with antibiotic-resistant bacteria. And that's not including the additional 223,000 cases and almost 13,000 deaths associated with C. difficile infection. CDC has identified 5 core strategies to combat antibiotic resistance, and the most germane strategy for this presentation is that of antibiotic use and access. What I mean by that is improving appropriate use, reducing unnecessary use, and also ensuring improved access to antibiotics when needed. As we're all familiar, antibiotic use can lead to adverse events and other complications. This is regardless if it is appropriate antibiotic use or not. But one statistic which really stood out to me as I was getting into this topic about 10 years ago, uh, about 1 in 1,000 antibiotic prescriptions leads to an emergency department visit for an adverse drug event. And we also know that antibiotic use is the most important modifiable patient risk factor for C. difficile infection. Most antibiotic spending in healthcare occurs in outpatient settings, as you can see from this graph. It looks like my labels for the bars got messed up a little bit, but the green bar represents outpatient settings. The middle bar, labeled number 2, is for acute care hospitals, and I believe number 3 is long-term care settings. But this is a study which was published maybe about 8 years ago, and it shows just the huge difference between these settings. And because of the volume in outpatient settings, it more than makes up for the more expensive antibiotics, which you see in inpatient settings. Also, we know that approximately 85 to 95% of human antibiotic use by volume occurs in outpatient settings. We recently looked at pharmacy dispensing data, and we found that antibiotic prescribing rates have declined steadily during 2011 to 2022. You can see that antibiotic prescribing during the pandemic is shown around the year 2020, and that was especially prominent within children. We have some of these data publicly available on our website. It's called the Antibiotic Resistance and Patient Safety Portal. But you can get on, you can play with different antibiotic class agents, you can play with variables like geography. But the map that you see in front of you shows that antibiotic prescribing, per capita antibiotic prescribing, varies widely across our country. You can see the swath of states from Louisiana extending all the way to West Virginia are among the highest prescribing states. And that map generally hasn't changed much over the last maybe 8 to 10 years. There's also many opportunities to optimize antibiotic prescribing. We know that at least 28% of antibiotic prescriptions are unnecessary, meaning that they provide little to no benefit. And even among the 72% of prescriptions that are likely necessary, there are still opportunities to improve the drug selection, dose, or duration. When looking at antibiotic prescribing for viral respiratory infections, we know that office-based settings have the highest visit volume. And you can see this by the chart in which these turquoise bars are labeled. And on the y-axis, you can see the number of visits. And you can see that urgent care is dwarfed by the office care volume, by the office-based setting volume. However, if you looked at the frequency of prescribing for viral infections, you can see that viral infections within urgent care settings are more likely to result in an antibiotic prescription. And there's indeed wider variability among the other settings represented here. The leading diagnoses for which antibiotics are prescribed are shown here in these horizontal bars. You can see the top 3 diagnoses are sinusitis, ear infections, and throat infections. And within the top, also within the top 8 infections include bronchitis, viral URIs, and pneumonia. So it's no surprise that within our program, when talking about outpatient settings, we highly recommend outpatient settings target acute respiratory infections. That is not to say that there aren't opportunities for improvement for skin and soft tissue infections and urinary tract infections, but if you're going to go for, I guess, the group of conditions that may provide the most bang for your buck, that's going to be these respiratory infections. Also, I'd like to highlight that these two, bronchitis and viral URIs, they should not be treated with antibiotics. So in some ways, strategically, and from like a quality improvement standpoint, it sometimes can make sense to lump them together and track them together. I just wanted to point that out. Also, I'd like to also highlight duration as a potential target. This is a graph showing the duration of antibiotic prescriptions for the treatment of acute sinusitis. The guidelines, they recommend 7 to 5 days for a good reason, because that's what the body of literature shows will provide a sufficient benefit for the patient. However, despite that, we know that the overwhelming majority of prescriptions for sinusitis are for 10 days. And even among those that occur for 5 days, almost all of them are for a macrolide, azithromycin, which we know isn't an optimal choice for the treatment of acute sinusitis. Using another data source, pharmacy dispensing data, This graph shows antibiotic prescription volume by medical specialty. Now, the way that these data are set up, they actually classify nurse practitioners and PAs as a medical specialty, and I think that's a little misleading because as a PA, I don't consider myself practicing PA medicine. I practice emergency medicine or public health maybe. So so another way to look at this is to lump them by profession, which I'll show you in the next line graph. But I just wanted to highlight for you that nurse practitioners do represent a high level, high volume level for antibiotic prescriptions, and the same goes with PAs. So as a program, we have learned by looking at these data that these two audiences are critical for us to include for outpatient settings. And I just wanted to share that message with you all as well. Now, if you look them all together, if you put all the physicians together, you can see perhaps a more accurate representation of volume by profession, and I think this is a good way to show that. Now, if you combine both NPs and PAs, you will see that we represent about 1 in 3 antibiotic prescriptions within our country. And this has changed drastically over the last 10 years. This stacked bar graph on the left shows you the 2011 antibiotic prescription rates by APPs. And you can see that NPs and PAs represent about 40% of all antibiotic prescriptions in 2011. And then in 2022, that has grown to about 36%. Among NPs, that has more than tripled from 7% to 23%. So again, really emphasizing the importance of NPs and PAs being a target audience for improving antibiotic use. Now I'll show you a different data set here. And what we're going to do is we're going to compare 2011, the rates per 1,000 population in 2011 versus the rates per 1,000 population in 2022. So I'll break this down by state, and I'm going to put each state on this graph showing how it has changed over that time interval. Now, if the state initials arrive in the green, that means that there's been a decrease in prescribing from 2011 to 2022, whereas if the state is in red, that means there's been increases in prescribing. Now, if a state is close to that dotted line, that means that there's been relatively no change during that time interval. This is a way to visually represent changes in geography over the time period. And as you can see, for the most part, there has been a lot of decreases in antibiotic prescribing among many states. I'd also like to highlight that there's a cluster of states in the top right of this graph for which are generally outliers compared to the rest of the states in the country. Also, I think it's important to note the distance of these states from the dotted line. Those that are further away means that they have experienced larger decreases compared to states that are closer to the line. So you can see North Dakota, Tennessee, Kentucky, and West Virginia have made big improvements during this time interval. However, if you look at Florida, Arkansas, and Mississippi, that change is relatively modest. Now I'm going to break this graph into professions, and I'm going to show you physicians, NPs, and PAs. And you'll notice that there is a difference between how this prescribing has changed among these groups. Physicians, by and large, have largely decreased over that time interval, but NPs, largely due to changes in the profession itself, i.e. a lot of growth among NPs and PAs, but you can see that NPs have largely experienced an increase in per capita antibiotic prescriptions during that time period. Nevertheless, some of the same patterns that we see in the larger graph still persist in these professions individually. However, within PAs, probably because they practice more medical subspecialties, they show a slightly different pattern during that time interval. I'm now going to jump into the second half of this presentation. That's going to be the common myths in outpatient antibiotic stewardship. And before I jump into this, I just really want to highlight what is our framework for improving antibiotic use in outpatient settings. So the core elements of outpatient antibiotic stewardship, which were mentioned early in this presentation, they are the commitment, action for policy and practice, tracking and reporting, and education and expertise. So I will go over these a little bit more in depth during the myths, but if you'd like to know more about the core elements, there's a document which you can find on the CDC website, or you can just Google the core elements of outpatient antibiotic stewardship. They were published in 2016. We recently reviewed the evidence for the creation of those recommendations, and we still think that they're very they're very relevant today, and there's only small changes that we would make as a program. So if we were to update them today, but I'll review some of those updates during this segment of the presentation. Now, the first myth which I'll highlight for you is that high prescribers know that they are high prescribers. And the truth is that high prescribers often don't know this. And that's why it can be important to have things like audit feedback in place and to have some sort of form of accountability so that prescribers know where they stand. Here's a quote from a meeting at CDC in which we gathered healthcare executives to ask them about this. The quote goes, high prescribers by and large did not know that they were high prescribers, and some actually believed that they were low prescribers. It was pretty remarkable, and I think that's very powerful. And this brings me to the core element of tracking and reporting, that is monitoring antibiotic prescribing practices and offering regular feedback to clinicians. At the organizational level, this often involves audit and feedback. This can involve assessing and sharing performance on quality measures and establish reduction goals. And also it can look like promoting continuing medical education to improve antibiotic prescribing and or motivating clinicians to track and improve their own prescribing. Now, what does a report actually look like? It's going to look something like this. This is modeled after a study, a telemedicine study, in which audit feedback with peer comparison was provided to prescribers. You can see at the top, the antibiotic prescribing rates for the targeted conditions are shown. That's bronchitis, pharyngitis, and sinusitis. And then in the middle, it shows the results of the individual prescriber. You can see that there's a number of visits, and you can see the antibiotic prescription rate on the far right. And then at the bottom is an element of peer comparison. Now, this is becoming more and more common, and for a good reason. There's good evidence to show that audit and feedback with comparison is more effective compared to audit and feedback alone. And so that is why, as a program, we do endorse healthcare organizations to use peer comparison where possible. And on the next slide, I'll show you how it matters the way that audit and feedback is provided. So for instance, if you were to compare a group of prescribers to the mean or median, the feedback that you provide will motivate prescribers to move towards that mean or median. And usually that's not desirable because you want your top performers to remain top performers, i.e. on the right side of that bell curve. In the second row, you can see that peer comparisons to top performers shifts this histogram to the right, and that is generally desirable. You want people to strive to perform well on these quality indicators. And then at the bottom, another alternative approach is peer comparisons targeting the bottom performers and try and get them to move to the right. That is an approach that is often taken by public health departments because it is relatively conservative, and it's easy to imply that these quote bottom performers have some opportunities to improve their prescribing practices. And indeed, public data are increasingly available to identify high prescribers. Here's a study which we published in MMWR several years ago, and we also created a graphic related to that study. And to encourage public health departments to target high prescribers within their jurisdictions, we actually provided a guide to help them facilitate that feedback. And this isn't just health departments; it's also health plans. So our Office of Antibiotic Stewardship, we partner with Blue Cross Blue Shield and other health plans to encourage them to do this because we think it works. Just based on the literature, it's an effective way to target prescribers and to get them to move towards a better antibiotic prescribing. But I'll show you a demonstration on the next slide of how these data can be used, but I also provided a screenshot on the right-hand side of the slide showing the interface that I use to pull these data. They are publicly available Medicare Part D prescribers, so obviously that's going to be a particular patient population that may be different compared to the general population, but I think the concept speaks for itself. I'll move to the next slide now, and it'll be, just a heads up, it'll be an animation showing what I was able to perform in about an hour and a half of using these data. And I'll say, as a data analyst, I would say my skills are about intermediate. I'm nowhere near the data analyst on our team, but I would probably say I'm pretty comparable to many epidemiologists, which you would find in public health departments around the country. So in this map, I created a cluster map of the top 1% of antibiotic prescribers in Texas using Medicare Part D data. And you can see this is a heat map of the top 1% of these prescribers. I'll now zoom in to a hotspot, which I found along the border. Many of the top prescribers are clustered along this particular interstate. Also, looking at prescribers in Houston, there are many top prescribers in the suburbs. At a high level, there appears to be more antibiotic prescribers in the top 1% in Dallas and Houston compared to San Antonio and Austin. Also, another way to look at this is looking at zip codes with the most unique prescribers in the top 1% of prescribers in Texas. Also, it's important to note that there are several locations outside of the major cities which may warrant further attention for stewardship efforts. So that data visualization, again, I put together in less than 2 hours. It's very easy to use if you have data analysis skills, and I use Microsoft Excel to do that. The next myth which I will share is azithromycin is a good empiric antibiotic choice for bacterial respiratory infections. And as many of you probably already know, azithromycin is not recommended for nearly all bacterial respiratory conditions. And so that begs the question, why? Why is this a poor choice for most upper respiratory tract infections? Is it because that there's elevated resistance to macrolides among strep pneumo, group A strep, and H influenzae? Is it because clinical guidelines do not recommend their use? Is it because the use of macrolides is strongly associated with macrolide resistance? Or is it that infection with macrolide-resistant pneumococci is a risk factor for treatment failure? As you may have guessed, the answer to this is all of the above, and this really gets to the core element of education and expertise. That is, providing educational resources to clinicians and patients on antibiotic prescribing and ensuring access to needed expertise on optimizing antibiotic prescribing. Also, it's important to note that inappropriate antibiotic prescribing is rarely due to clinical knowledge gaps alone. So it could be important to have ways to provide active education strategies to facilitate behavior change. Some examples of that might be face-to-face educational training or academic detailing, some educational activities for clinicians, and also ensuring access to persons with expertise. But indeed, azithromycin is not a good empiric antibiotic choice because of high rates of resistance, risk for treatment failure, and high levels of resistance among common bacteria. One particular study which I like is a study by Steinem and others. It was published in JAMA Network Open. It showed what a comprehensive educational intervention could be. And this particular study rolled out these interventions in urgent care settings. They included a stewardship champion. They had peer-to-peer education provided to clinicians. They created a handbook with guidelines so you kind of have a clear idea of what the organization expects of you when it comes to prescribing. Also, they created education materials, and they also created metrics which were shared with providers before they were measured on them. So that highlights an important point that it can be helpful to facilitate feedback from clinicians within an organization to make sure that they have a high level of buy-in for these metrics. Also, they had monthly update lectures. They updated their clinical guidelines for their institution, and they also had a web page which was specific to clinicians. And they even had what I thought was a pretty simple but creative and easy to implement intervention of just having a screensaver on screens which promote appropriate antibiotic use. But going back to that point that I just made, passive education has minimal impact on antibiotic prescribing. So things like brochures or just doing lectures, it's important to acknowledge that those are limited in their effectiveness because they fail to address the underlying causes of inappropriate prescribing. Often those are going to be psychosocial, such as perceived pressure to satisfy patients and many other complex factors which occur during those visits. I already mentioned active education strategies. An example of that might be peer-to-peer education. Those have greater effect. And things like interactive educational meetings or audit and feedback, they generally tend to work better. And there's a very consistent line of literature which shows that. The next myth is that every patient with an ear infection or sinus infection requires immediate antibiotics. And I'd like to bust that myth by emphasizing that delayed prescribing or watchful waiting are guideline recommended strategies for these infections. And this brings me to the core element of action for policy and practice, and that is implementing at least one policy or practice to improve prescribing, assess whether it's working, and modify as needed. Some examples of these interventions might be communication skills training, requiring explicit written justification in the EHR for non-recommended prescribing, and or clinical decision support. Other organizations have used call centers, nursing hotlines, or pharmacist consultations to prevent visits from happening in the first place. And then finally, watchful waiting and delayed prescribing practices can be appropriate for some of these visits. For those of you who may not be familiar, delayed prescribing refers to giving a prescription to the patient and instructing them not to fill it unless they worsen or unless they do not improve within a specific time period. You can also put an expiration date on the delayed prescription, which many pharmacies will honor. Delayed prescribing has been shown to reduce antibiotic use. This graph shows the proportion of patients who did not fill their antibiotic prescriptions for ear infections within a group of pediatric emergency medicine patients. Also, between these two groups, there was no difference in serious adverse events, and you can see those with delayed prescribing were much more likely to not fulfill their antibiotic prescriptions compared to those with a regular immediate prescription. I'd also like to highlight that interventions can be integrated into electronic health record systems. This isn't something that's going to be practical for many smaller organizations, but for larger clinic networks and for health systems, this definitely is something that is feasible and has been shown to be effective. Oftentimes, there's going to be a quality improvement program that can already integrate some of these things, or they may have an established antibiotic stewardship program. But examples of these interventions might be delayed antibiotic prescriptions, justification alerts, templates, or dot phrases that can be integrated into a clinical note. Those can also be very helpful in speeding up some of these visits. Also, pre-populated orders, also a form of clinical decision support, is another option for these types of interventions. And we do offer resources for delayed antibiotic prescribing. You can check these out on our website. And also there is a resource for watchful waiting as well. As I close out this myth, I just want to emphasize that delayed prescribing should only be given for conditions for which they benefit from antibiotics. So, for example, for a viral URI or a throat infection that tests negative for group A strep or acute bronchitis, those are situations in which a delayed antibiotic prescription would not be appropriate. Other interventions to improve prescribing might include a prescribing dashboard, which can be shared across all clinicians and clinics. And also financial incentives are an area which have a growing body of literature to support their use. Now, the final myth which I will share with you is about patient satisfaction. Now, the myth is that not prescribing an antibiotic will negatively impact patient satisfaction. And I'm going to break this down because this literature has been growing a lot in recent years, and I'm excited to share some of the results. But what I've found is that the results are also very nuanced. I'll start with the statement that antibiotic prescribing is associated with patient satisfaction. And I'll lay out a few other statements here, but I'll go through them and label them as true, false, or it depends. Now, regarding whether or not if prescribing is associated with patient satisfaction, in this case, I would argue that it depends. Let's have a look at what the literature says. In that study that I mentioned earlier for urgent cares, the main author, the first author, wrote that despite the substantial reduction in antibiotic prescribing within this health system, patient satisfaction scores remained unchanged following the introduction of the intervention. This is a similar finding which was observed in a large study of general practices in England, wherein the authors observed a 25% reduction in antibiotic prescribing, which was associated with a 0.5% to 1% reduction in patient satisfaction. Similarly, in a large U.S. health system-based study of 5,000 sinusitis visits, the authors compared a group of patients which received antibiotics versus those that did not receive antibiotics, and they looked at their patient satisfaction scores. And they found that visits with favorable satisfaction scores did not differ between the two groups, or at least the difference was less than 5%. Also, stronger satisfaction scores were associated with older age, more comorbidities, and an established patient-provider relationship. In another study of emergency medicine Press Ganey scores, the authors found that when comparing the antibiotic groups of patients which received an antibiotic versus those that did not, the differences in Press Ganey scores was relatively small. You can see in the top two bars of the stacked bar chart representing very good and good, the differences were relatively minimal. The next statement is whether or not, the next statement is that patient satisfaction is associated with expectation for antibiotics. Now, again, this depends. And I'm going to show a study which looked at expectation scores and also patient satisfaction scores. And it's a really interesting study, and I'm excited to share it. Now, what this study has found is that patients with high expectations for antibiotics were less satisfied when antibiotics were not prescribed. And I think that's pretty intuitive. I think that's something that we can all sort of maybe knew in the back of our minds, or maybe that was our gestalt. But this is a study which actually shows that. Now, what they used was patient surveys across 32 urgent care centers, and they measured expectation and patient satisfaction scores on a 5-point Likert scale. And as the graph shows on the right, high expectation scores were associated with low patient satisfaction when antibiotics were not given. Conversely, low expectations for antibiotics were unaffected. So, and the other thing that the authors noted was that expectation scores did not differ by age, ethnicity, race, or education level. Now, what I draw from this is that overall, patients with high expectations for antibiotics are generally not going to be as satisfied if they don't receive antibiotics. Whereas most patients, which don't fall into that category, most patients are going to have low to intermediate expectations, but for the most part, we are able to influence patient satisfaction for the overwhelming majority of these patients. And then the next statement is that clinicians are more likely to prescribe antibiotics to patients who believe they expect them. Now, this is something which has been true in the literature for some time now, and I'll share what some of those studies look like in the next slide. But before I do that, let me just share one more statement, and that is that that providers, in this case I put physicians because that's what the studies were performed on. That's who the studies use for their participants. And the statement is that physicians can reliably predict which patients expect antibiotics. And in this case, that statement is actually false. Indeed, clinicians are more likely to prescribe antibiotics to patients who they believe expect them. And surprisingly, we actually do not reliably predict which patients expect antibiotics. Among adult patients, we correctly identify about 1 in 4 patients that actually expect antibiotics. And I think that number is about 1 in 2 for pediatric patients. Also, interestingly, non-antibiotic prescriptions, say for symptomatic treatment, maybe Tessalon pearls for acute bronchitis, are also associated with higher levels of patient satisfaction. So going back to the myth that not prescribing an antibiotic will negatively impact patient satisfaction, I would argue that the association between antibiotic use and patient satisfaction is actually very nuanced, but relatively small in magnitude. And perhaps the best intervention that we have to improve antibiotic prescriptions, to improve patient satisfaction with these visits is communication training. And this has been explored as a public health intervention. And and studies have found that enhanced communication training, it improves antibiotic prescribing. It appears to be sustainable over time, and it is associated with increases in patient satisfaction. Now, where can you get communication training? There are 2 sources. There is a course on our website. It's a longer course, but a little bit more. It goes more into depth into literature, and I highly recommend it. But also, if you wanted something a little bit more quick and to the point regarding communication training, I think the DART method, or the Dialogue Around Respiratory Illness Treatment from the University of Washington, is an excellent choice. And I'll wrap up this presentation by reviewing some other smaller myths which I didn't have time to get into today. And those myths are PAs and NPs do not have a role in antibiotic stewardship, that antibiotic stewardship programs are only hospital-based, and that virtual visits are acceptable for the evaluation of all respiratory infections. Now, my challenge to you, listeners, is how would you modify these bullet points to make them true? These are currently written as if they are myths, but what edits would you make to make them true? Some of the things that I would change are that I believe that PAs and NPs do have a role in antibiotic stewardship, especially in the outpatient setting where they make up a large portion of the workforce, and antibiotic stewardship programs can focus on outpatient settings. And then finally, virtual visits are not always acceptable for the evaluation of respiratory tract infections. I didn't have time to get into it, but the 2 conditions which cause our program a lot of pause is our pharyngitis, group A strep pharyngitis testing, and also the evaluation of acute otitis media because of the absence of an in-person physical exam. Now, there are ways that that platforms are overcoming that, such as virtual otoscopy, but I think we're still waiting on more studies to show that that is a reliable and accurate way to diagnose that condition. So take-home points from this presentation are that respiratory conditions remain high priority improvement targets. High prescribers don't know that they are high prescribers. Azithromycin, generally not a good choice in outpatient settings, and not all bacterial infections need antibiotics. And then finally, it is possible to improve antibiotic prescribing with minimal changes to patient satisfaction. Thank you.
Thank you so much, Memo. I really appreciate the time that you took with us today. We are going to open it up for some Q&A. So in the Teams meeting in the top corner, you will see about mid-screen, there's a Q&A box. If you have any questions for Memo and like to put those in the Q&A box, we will get those answered. And while we wait for any questions that may come across, I did want to let those on the phone know that our HCSC providers, if you are an HCSC high prescriber within our federal employee population, we did send out letters back in April to our prescribers for those that are considered AAB, avoidance of antibiotics for acute bronchitis or bronchiolitis high prescribers. So those letters would have come to you back in April. We will be sending those out again in 2025. So definitely keep an eye out because we know that we want to not be on that list. So hopefully we will not have that issue. At this time, we don't have any questions. Mackenzie, is there a way if people have a question that they can come off of mute?
Unfortunately, there is not, as this is a town hall.
Okay. Ready. Well, if that's the case and we don't have any questions in the next moment or two, then what we'll do is we'll go ahead and wrap up. Memo did put his email here for anyone that may have any questions following. Mackenzie will go over the next steps in regards to getting your CMEs for this course. And I truly appreciate everybody that took the time out of their day. I know it may be a little bit early for you and you may be missing some patients in practice or anything like that, but I really appreciate you taking the time to listen to Memo about antibiotic stewardship, as we know how important this really is overall for our members. Thank you again.
Thank you everyone for being here. The next steps are within the next 24 hours. I will be sending an email. The email will come from mackenzie@montstuli.com with instructions on how to receive your CME for this event. We also have recorded this event. If you want to go back and watch it again, you're more than welcome to. Or if your friends missed this event and they would still like to claim CME and watch the recording, they're able to do so. I will send all this information via email within the next 24 hours. Thank you.
Thank you, everybody. And with that, that concludes our presentation. I hope you have a great day.
Thanks, everyone.